Hi, and this is another edition of Uplift the Menopause Conversations. Now, the conversation is it's going to be slightly different. It's not only about menopause, it's really about women's health and what we should be checking for and things like that. But fabulous women here who could tell us themselves what we are discussing. So the first person that we have today, Dr. Mandy Yip, I'm sorry. Dr. Mandy is a GP in the Prestwich area community, in the Jewish community, so she knows very much what's happening in our community. So she could really come to it from that point of view, which is what we wanted. And the second person we have is Lucy Durber, and Lucy is a cancer care coordinator for Prestwich. Mandy and Lucy got together through that. And I am really, really excited about this conversation. I know it's not a exciting conversation because at the end of the day, we're talking a little bit about cancer, but I still think it's exciting that we can talk about this openly, get the conversation out there, get people to ask and to, get involved. If you have any questions, please put them at the end of the talk. Always, you can always send them in. I'm going to first let Dr. Mandy, if you could just introduce yourself a bit more than I did, and afterwards Lucy, and then we'll go into what you do, and we'll start it that way. So, hello, welcome.
Hi, I'm Dr. Mandy Yip. I'm a salaried GP in Prestwich in Manchester, and I'm also the cancer lead for Prestwich Primary Care Network.
And Lucy?
Hiya, I'm Lucy. I'm the cancer care coordinator for Prestwich Primary Care Network. So I'm a single point of access for all patients in Prestwich with cancer, so supporting them through it afterwards and anything like that really in the community. Yeah, so I think there was a bit of a project around primary and secondary care, so GP surgeries and then the hospitals. And I think once somebody had come out of the hospital, they felt like they've just been dropped off the system. So they still had cancer and they still needed supporting, but they wasn't getting enough from the hospital. So that's where I sort of joined the gap between the two.
Stuff. So I think that's what happens. You are let out of the hospital. You're in a very vulnerable situation. You're feeling like no one's going to be there for me. And then, there's nothing. So I think that's a really important place to be. So I'm glad there is something that we have in place for that. You have a scoping project to understand barriers in the screening in the Jewish population, right? So I want to understand a little bit about that. What do you think that there's barriers from your point of view? And then I'll tell you a little bit about my point of view so we could just see if we're all on the same page. So who wants to take the lead on that?
So, sorry, I will.
Okay.
I think the main scope of the project was that we didn't know the barriers. So we just knew that the numbers were lower in the Jewish population for cervical screening and things like that. So we wanted to know why and how we could overcome that really. There is a few, speaking to GPs, like Jewish GPs and things like that, that we've picked up on, but we're still not really much closer to overcoming the barriers really.
Right. So what would you think the barriers are from your point of view? Mandy, you've worked in GPs in the neighborhood. So what would you think the barriers are? And then I could tell you what I've come up with, because I think the barriers are slightly more nuanced than we realize.
So I think some of the barriers that we think that to why women might not attend for their smear test or their cervical screening is, what they might not understand what the actual test involves. And a lot of people might think, oh, it's quite a painful, it's not a very nice procedure. So in terms of to overcome that barrier, there's an option of speaking to your nurse or your GP prior to your smear test to ask any questions or concerns that you might have and overcome any anxieties that you might have regarding the test. And in terms of the test, what it involves is either a nurse or a GP doing something called a smear test. And essentially it involves a smooth sort of tube-like tool called a speculum, which is inserted into the vagina to look at the cervix, which is the opening to the womb from the vagina. And essentially, the clinician will look at the cervix to see whether there's any visible changes. But also, they will use a very soft brush to take a sample of the cells of the cervix and send it to the lab to see whether there is any changes and whether there is something called a human papillomavirus, which some high-risk HPV, some high-risk virus, can cause cervical cancer. So I think one of the main barriers would be that women think that, they're worried about the pain and the discomfort that the test might entail.
Right. So when you're making the test, because the truth is, I wish we had one just to show, but it's thinner than this, if I'm right. It's thinner than a pencil, the stick.
Yeah.
And at the end, there's like a Q-tip that you put into your ear. It's very thin and a very small bud. So you don't really feel that. Yes, you might feel when they're opening, the vagina with the speculum that it's uncomfortable.
It's uncomfortable.
It's not
yeah.
more uncomfortable than anything else that they do when they're checking for anything, right?
Mm.
So I think we should make that clear. I think also a lot of Jewish women would most probably worry a bit about the bleeding part of it, because we have, law explained to me what blood they could see, and if any.
Yeah, so after the smear test, not everyone, but some might get a bit of light bleeding or some spotting, and that should only last for a few hours and nothing more. Obviously, if women or anyone with a cervix that has the smear test experience more bleeding than a few hours or more than a light spotting or light bleeding, then they should consult their GP. But it should only be very light and only for a few hours, and not everyone experiences it.
And would it be from the vagina or from the cervix that the blood would be coming?
So
would it come from the walls, or would it come from deeper?
It will just come from the walls and just from the opening, just from where the speculum has been inserted. But also during the procedure, they use a lubricant on the speculum, the tip of the speculum, so that will help with the insertion and the ease of the insertion into the vagina. So that will help to also prevent any bleeding or discomfort. And like you said, in terms of the speculum, it is very small, and there are different sizes for different women as well. So obviously the clinician will take that into account and use the most appropriate size speculum.
Okay, so I think that this is something that would most probably scare a few women about this bleeding problem. So it's not something that everybody gets, and it's definitely not something that's always going to happen. It's very.
I don't know in terms of the statistics, but it's not. It's
not everyone.
It's not everyone. Yeah, but it can happen. Yeah.
Okay, I think that's a real worry. Another thing I would think that's worrying our women is a lot of us have dryness, especially at the age of menopause. So how would they deal with that?
Yeah, so in England, the cervical screening is aimed at women between the ages of 25 to 64 years of age. So, some women that have gone through the menopause or are going through the menopause might not think that they need the smear test, but they are still within that age group. So in terms of, a lot of women going through menopause or even after menopause might experience the vaginal dryness that you were mentioning. I'm not sure whether women are aware that you could ask your GP for prescribing some vaginal estrogen, which you can use prior to having a smear test, and that will help with easing the dryness and help make the test more comfortable, essentially.
Wow. Would you use that even just for that day? Let's say somebody doesn't want to take that full time. Would you be able to get something like that just for that test? Or
yes, you can, yeah. And I would recommend you to use it a few weeks before the smear test, so it will have more of an effect rather than just the day before. Yes.
I personally recommend it for everything because I think it's such a savior for that problem. Definitely, it's amazing. Okay, so now, Lucy, do you have anything to add to all that?
No, that was really good. Yeah.
Okay,
yeah.
Very good. So I think that's the two things that I would have thought that would be barrier is the pain and the bleeding. And I think that we've, covered that. And I think also maybe women don't feel like they need to do these things. Oh, I'm not, it's very not prone, the Jewish community. The Jewish community thinks that cervical cancer is not so much their problem because, we have one sexual partners. Usually it's not.
That's
So
what I was
what
going to
would
say.
you,
It's sort of
yeah,
it's linked to promiscuity, which isn't really in the population because they
community.
have one
Yeah.
life partner. Yeah.
Yeah, but would you say that that's true, that you don't see it because of that, or is that just like a little bit of a myth?
I mean, it's a bit hit and miss, really. So it is linked to promiscuity, the HPV, but we're also seeing younger ladies that have only had one partner or maybe no partners popping up with it just randomly. So it I don't think it really matters. I think it's if you're in that tiny group of people who might not get it, you've still got a chance. There is still a chance, so it's still worth getting it checked.
I actually had a friend who died from that. So, I remember when I went to visit her, it was towards the end, and she said, "Oh, I know everyone must think I must have had." I said, "No, I know that's not true." So she goes, "Yeah, but that's what they come up with. That's the first thing they say. Did you have a lot of partners?" And of course, I knew it wasn't that way. It's just that she was, like you said, she was one of the millions who got it, and we do have to be careful, to take care of it. Okay, so that was a really good thing. Another thing, I mean, we mentioned is where we have the screening done. We were talking about that when we had our first conversation, and we were saying, would that make a difference? I personally have not found that it would make a difference. I think that people were quite open to having it done by their doctor, and on the contrary, wanted it done not by a Jewish clinic, which was also very interesting to me. So that I think is good to take on to board, that, we're open to this, but we just have to be reached the right way.
And I'm not sure whether people are aware, in a lot of areas in Manchester and in England, we do offer extended access appointments as well. So, if someone can't attend a appointment during normal working GP hours because of work or childcare, there are appointments available at weekends or evenings, and there are nurses that are available the specific nurses appointments for the tests for this. So, yeah.
It's very interesting that we were talking about the times that are available for thing. Another thing is, people should know that if they have to discuss something with your doctor, you could sometimes order instead of a 10-minute appointment, you can ask, can I have a double appointment?
Double one, yeah.
By most surgeries. Am I right?
Yes, exactly. Yeah.
Yeah. Okay, so now let's go on to, let's say, bowel screening. There's so many different screenings. That's the truth. There's so many different screenings available. What's important? What's not important? What should we do? What could we do at home on our own? What can't we do? Could we go into that? First of all, age-wise, is there something that our age group, which is middle-aged women, should be doing extra? So let's start that part. So Mandy or Lucy.
So bowel screening is available to everyone aged 54 to 74 years. It is gradually coming down in age, so to be available for everyone aged 50, so 50 and 53 are also being invited now as well. So if you are getting a kit sent earlier than that, that is completely normal. So it is being rolled out now. So with bowel screening, you use a little kit called a fit test. So I think people before might have been used to the kit where you used to have to send 3 samples in a week, but that's now stopped, so you don't have to do that. And I understand why people didn't particularly want a bit of card left on the side in the house. So they have made it a lot easier and a lot more clean, really.
Yeah, I think more pleasant.
Yeah, more pleasant. Yeah,
more pleasant.
I've not done it yet, but yeah, a lot more pleasant.
Okay, now I think again, I'm showing you how small the thing. I wish we would have bought
It's tiny. It's tiny. I wish I had anything
to show it. It's like a toothpick, right? Even it's really small. It's like that. I would say a very small stick with like a spoon or something at the end.
It's like a little brush.
Scoop it and you put it in. and it goes in a little bottle, so it's not at all messy. And it's just, it's like changing a child's diaper. I'm sorry. That's what it is. It's nothing. You know what I mean? And I think that when you say to somebody, "Oh, you gotta have a bowel stool brought in," oh, I don't do that. That's disgusting. But it isn't disgusting. It's for your health, and it really isn't disgusting. So, what are we looking for when we do that?
So they're
We're
looking
sending
for,
it in, and
yeah, they're looking for blood inside, so tiny little bits of blood inside the stool. Obviously, if they don't find anything, it comes back negative. If they do, then it comes back positive, and we have to investigate that a bit further on.
okay, okay. So that's one test. And what other ones would you? Then there's, I think, breast cancers. Let's go into all these tests that they do. So, Mandy, what would be another one?
So if we're talking about breast screening at the moment is every 3 years, women are invited between the ages of 50 and 71. And that essentially you get invited for a mammogram. And what a mammogram is kind of x-rays that you will have of 2 for each breast. And the appointment would only take, the mammogram itself should only take a few minutes. The whole appointment, probably 30 minutes. And obviously, depending on the result of the mammograms, if it does show something, you will get invited for further tests, so examination of the breast, more mammograms or ultrasounds, so like a jelly scan of the breast. And if there is a lump that is found, maybe a small sample might be taken or a biopsy from the breast. But it's really important that even though we should attend these routine breast screening or bowel screening, etc., that if you notice any signs and symptoms of bowel cancer or breast cancer, you should consult your GP or doctor or nurse. And for breast cancer, I think it's really important that women regularly check their breasts and self-examine. Everyone's breast is different shapes, different sizes. One breast could be bigger than the other, and that's normal. And so I think it's important for women to know what their normal breast feels like.
Yeah.
And also your breast can change in the way that it looks or feels depending on where you are in your cycle. So for example, if you are on your period, then your breast might feel more lumpier or more tender. Whereas if you've gone through the menopause, they might feel softer and less lumpy. So important to know what is normal for you. And in terms of signs and symptoms, if you notice a lump, any nipple discharge, changes to the nipple, such as the position of the nipple or if it starts to turn inwards, any rashes that don't go away, always check your breasts, both armpits up to the collarbone. And if you notice any of that, go and see your GP.
So people get very frightened of it. And from my experience, it is a little bit, it's not pain-free. It definitely is a little bit more tender. I mean, no, I don't care what anyone says. I'd rather be truthful and say, yes, it is a bit tender, especially if you're a bigger breast. It's even sometimes more tender, or if you're very small, it's sometimes very tender. It depends on your size, but it's not undoable. And it's not something that you can't do. It's not going to kill you for 3 days or 4 days and you can't move. And it's not like that. It's just you feel tender. That's it. It hurts a bit. But I feel when you finish, and also when they want to check you and recheck you, it's not the end of the road. That doesn't mean that you have cancer. Because I think that's also another thing you're scared of. You're scared that, oh, why are they taking it? Why are they redoing that test? Why are they calling me back? Doesn't mean anything. It just means that they're checking to make sure that there's nothing wrong. And sometimes it's just a little thing. It's nothing. It's just how your body is made. And I think that's important to get across before these tests, because all these tests are something, I'm going to go on and on about this, but we must be doing it, because especially breast cancer. I mean, the BRCA gene and all that. Could we go into that a little bit? Because we are very prone to this, having this gene. So let's talk about how that one works.
Yeah. So a lot of people might have heard about the BRCA gene. So it refers to 2 genes. You've got the BRCA1 and the BRCA2 that everybody has. And these BRCA genes play an important role in the prevention of cancer. Some people, unfortunately, might have a mutation or a fault in one of their BRCA genes. And having a BRCA gene fault puts you at increased risk of developing certain types of cancer, specifically breast cancer, ovarian, prostate, and pancreatic cancer, especially because we work in Prestwich, in an area where there's a large Jewish population. It is useful to know that having Jewish ancestry increases your risk of having a BRCA gene fault. So just a few kind of statistics. So in the general UK population, about 1 in 250 individuals, in terms of women, they will have a risk of developing breast cancer in their lifetime. If you are an Ashkenazi Jew, that risk is increased to 1 in 40 in the lifetime risk of having the BRCA gene. And if you're a Sephardi Jew, 1 in 140 to have the BRCA gene fault. But in terms of, for example, breast cancer, because you're at a higher risk if you have the BRCA gene fault, on average, 11.5% for a female lifetime risk in the general population. If you have a BRCA1 gene, that risk increases to 72% in their lifetime. And BRCA2 gene, 69% lifetime risk. Yeah. So that risk does increase quite a bit if you've got a BRCA gene fault. And it's interesting because at the moment, NHS has started a new BRCA gene testing program for the Jewish population. And I believe that is already an approach that's already adopted in Israel. So medical research has shown that it is now best practice to offer BRCA gene testing to all Jewish people, irrespective of their personal history or family history of cancer. And if anyone is interested, anyone that's living in England, aged 18 or over, with 1 or more Jewish grandparents of any type of Jewish heritage, is eligible to take part in this program.
BRCA gene thing. So you're saying really everybody should have it. It's not only women who have a history of cancer in the family.
In terms of Jewish people?
Yeah.
Yeah, I mean, you mean in terms of the gene testing that everyone should
Yeah,
have?
yeah, about the BRCA testing, yeah.
Yeah, I mean, it really depends on the individual. There's lots to consider, isn't it, if you want to have the gene testing, because it depends on the stage of life that you're in, whether your family is complete, whether you're going to have children, whether you have children. It doesn't only just affect you knowing whether you have the gene or not, the gene fault or not, but it also affects your relatives and your children as well. So I would recommend, if people are unsure, talk about it with, family, friends, or even a clinician, your GP or nurse, whether you should go ahead with having the gene testing. But it is available. It is out there for people to have and to consider to get if they would like.
Really interesting. You could go to what is it?
Genetic counseling?
Therapist. You could go to, a therapist to help you make that decision, because not everybody is geared up to doing that. It does change your life. If you find out you have it, it makes a massive change. Sometimes people would say to themselves, I'd rather live with the risk than live with the knowledge. So I think that's important that we have that in mind, that people could go have a discussion beforehand, make sure that you're ready for it, because it's something that is going to definitely change who you are. And like you said, your children's lives, everyone's lives will be affected by this. So it's very important to go through, to pre-counseling. And then definitely, if you're up to it and you're ready for it, it's a really good thing that we were given this opportunity to check this out. All right. And then we were talking about ovarian cancer. Is there any checks that we could do for that, or?
There's no screening for it, really. I don't know if you want to talk about the signs and symptoms of ovarian cancer.
Yeah,
I want you to talk about it. Yeah.
So in terms of ovarian cancer, like Lucy said, there isn't any current screening program in England at the moment for that. But unfortunately, ovarian cancer is something that is usually picked up quite late, just because the signs and symptoms are quite vague. So we would recommend any women with any symptoms that are persistent or frequent, meaning that it happens about more than 12 times per month. If they get things like bloating, you're feeling full quite easily, loss of appetite, pelvic or abdominal pain, or symptoms such as increased urinary urgency or frequency, then they should see a doctor about it. I mean, these symptoms are quite vague, so it can overlap with other conditions. It doesn't necessarily mean ovarian cancer, but I think it's important for the public to know what things to look out for, when to see a GP, but also my role as the cancer lead in the primary care network is to also educate clinicians to know what signs and symptoms to look out for and to consider cancer if a woman comes in with persistent bloating, to do those tests, if necessary tests, which might include a blood test or an ultrasound to see whether a woman has ovarian cancer.
When you're going through your menopause, a lot of those symptoms are so similar that, they really overlap. So the clinician definitely has to know what they're doing. But we also, as women, we have to, even if you go to your doctor and you feel like a fool when they tell you, oh, it's nothing, it's just your way of, it's okay, so what? Thank God they told you that, It's better they should tell you that you're being, it's nothing, than to tell you it's something too late. So always make the step to go to your doctor. You have something that's bothering you. Don't worry what they'll think about you. They don't think what you think they're going to think, right? Mandy, answer that one. When we go in and then we've sat there for the 10 minutes and we sounded out about all these symptoms and pains and everything, you don't think we're crazy. You're happy to tell us when it's nothing. Am I right? I don't know how it works on the doctor's point of view, but I know as a person, we're always worried what the doctor's going to think. And I think I'd love you to make that, to show people that it's not true what doctors don't think that.
No, I think it's really important for the doctor or nurses or any clinician to really try and understand the patient's story and what their concerns are, because the patient has come to a trusted clinician to tell them about their concerns and worries, and if cancer is something that they're worried about, we need to take that seriously, and we need to ask the appropriate questions, do the appropriate tests if we think that's necessarily, because we should take patients' concerns seriously and we should listen to them.
Yeah. And it's so important for us to make sure to just keep on doing these tests, keep on going to your GPs, and don't feel uncomfortable about it. That's their job. That's what they get paid for. And it's your job to go to them. They have the knowledge. They've learned about this. And that's what they're there for. Okay, so now we've done breast cancer. We've done the brackaging. We've done breast screening. We've done cervical smears, bowel cancer. Is there anything else that you could add to all this that we should take into account? Lucy, if you want to start.
The only other one really that is prostate cancer. Obviously, it doesn't relate to women.
But I think women, it does relate to this.
Yeah, passing it on to the husbands or partners, whatever.
Yeah.
So with that test, we just wanted to really make it clear that there's no, for the prostate cancer testing, there's no screening for that either. And it is a blood test, so there's no examination. Because a lot of men, when you say you need to go and get a prostate test, they think it's an internal examination, which it isn't. Something might lead on from the blood test to an internal examination, but the initial, obviously, examination is just a blood test.
And I think what they're looking for is the numbers if they're going higher. And then it doesn't mean right away it's cancer, because sometimes men, as they get older, that their numbers start going. Could you explain that, Mandy, what happens with the numbers so that we can understand it?
The reason why there is no current screening program is because the blood test, like Lucy said, is a simple blood test, but it could be normal even if you have prostate cancer, but it could also be positive if you have other conditions, such as if you've had a recent urine infection. Like you said, as men get older, your blood test level to go up. And yes, initially it would probably be blood tests, but it is useful to have the examination alongside, because like I said, the blood test doesn't accurately rule out cancer, any concerns that you might have about that. And prostate cancer is a slow growing cancer. So there are a lot of treatments that are available. So especially like I mentioned before, if you have the BRCA gene fault, you are at increased risk of prostate cancer. So it's useful for Jewish people to know that, and to, again, see your GP if you have any, your frequency, going to the toilet more at night, weight loss, bone pain or back pain that is unexplained or doesn't go away. That can sometimes mean prostate cancer spread. So those are useful kind of information to know what things to kind of look out for when to see your doctor.
It's really important for us because, we're married, and it's our job to tell our husband, go check.
Yeah.
Most of the men sit there and go check yourself out, go take care of yourself. But we forget that they also need to take care. Men are more reluctant to go to doctors. They don't love. They're not there as many times. I think women are geared towards looking for our bodies. We're looking for these symptoms. We've been brought up with it. Men, they don't really know as much as us in that, and it's important that we encourage them to go to check it out. And it's not going to be, by the way, I think prostate cancer is one of our biggest cancers amongst us. I don't know if you know the figures on that one, but I think if I'm correct, then prostate cancer is one of the ones that really affect our community. So I don't know if is it true?
Yeah, so like I said, obviously with high risk of having the BRCA gene fault, and specifically prostate cancer is one of those that that men are at increased risk of.
Yeah, definitely. I know a few people who have it, and also it doesn't mean the end of your life, because like you say, it's a slow growing one, and there's a lot that they could do with many years of living comfortably with it. So that's very important to know.
Obviously,
Okay.
because it's still if it's a primary cancer, it can spread. So it is important to get it caught early as well before it spreads anywhere else.
Okay. So now I think that we've done quite a lot here, and it was really interesting for me also, and I hope everybody else found that interesting. Is there anything you want to add to all this, or that we could end off on, to give everybody that push to sort this all out, to take tests, is there anything that you'd like to add? So if we start with, let's say Mandy, and then we'll go to Lucy. Yeah.
I think the main message that we wanted to get across in today's podcast is the importance of, the public and clinicians to be aware of signs and symptoms of the different cancers, especially in the Jewish community, and the importance of attending and mammograms, because it's important for us as clinicians, as the public, to diagnose cancers early so people have a better prognosis. And lung cancer, if you smoke, there's an increased risk. So helping patients prevent cancers from getting cancers in the first place.
Really, if you have any thoughts in your mind, then it might be something to bring that up with your GP, just so they can reassure you, instead of you going home from that appointment then still thinking about it and then making another appointment and maybe it's still not resolved. Then just let somebody know, either your nurse or your GP. And obviously we have one specific GP practice in Prestwich that only has a male GP. We've got the extended hours appointments to see a female GP if you needed to as well.
Oh, that's interesting. That's good to know that. I'll tell you what, when you were saying about telling your doctor not saying it the first time, not saying it the second time, but really wanting to ask the question. I don't know if it's true if you've seen this, but I know that I once read something, and it said that the last 3 minutes of a patient's visit to the doctor is the most important. Remember to tell you what you really came in for, because that's the thing that you really need to speak about. Please don't be embarrassed. Please speak to your doctors. What we read and what we learn, what we live by, it says that it's very important to take care of your body, yourself. So let's all do that. Thank you so much, Mandy. Thank you so much, Lucy. I'm sorry, but thank you very much, both of you, for your, for coming on here, for bringing this all to our attention. And I just wanted to say one more thing about a GP. I usually explain a GP in England is not the same thing in every country. So we're very, very lucky here in a way that we have GPs that are open and understand everything, and they know where to send you further, which is fantastic. So again, thank you very much for joining us. And I can't wait to see everybody else again. If you need any information, I'm going to put below, I have an article we have on breast cancer, how to detect it, because I think this is all so important. So again, thanks for coming. It was nice to see you all, and can't wait for next time.
Yeah, thanks for having
Thank
us.
you.